Hello, everybody. This is Nick at NECADE, New England Center for Advanced Dental Education. I want to start a continued series called The Case of the Week. This is the first one. The goal is to take an actual clinical scenario that was difficult to diagnose, difficult to execute, and share what we did and what we learned from it. This particular case, we can call this the less than obvious odontogenic diagnosis. So this is the patient that comes in, doesn't have anything that's very obvious on the x-ray, yet they have pain symptoms, so on and so forth. All right, so the goals of this case vignette are: one, to discuss a methodical process for difficult odontogenic diagnoses. These happen in our clinical practice each and every day. The question is, when they're difficult, what do we do about it? We're going to have a brief discussion on endodontic and periapical diagnosis and how they can relate to occlusion sometimes. We're going to discuss how to deal with occlusal interferences, specifically posterior interferences. We're going to discuss when must we be careful when re-cementing a crown. And lastly, we're going to display a case, the case vignette, on how we can use these frameworks to get a patient out of pain when the diagnosis is not super obvious. So here we have the patient in question. History of the issue. Number 30 had an eMax onlay that was placed about 10 years ago. It was done with CEREC technology, and the patient has had no issues ever since. This patient has been in practice for the past several years, and she presents with a history of occlusal disturbances, TMD, stress-related function and parafunction. Long story short, this is a type A kind of individual that just tends to create a lot of biomechanical stress on their teeth as a result of psychological stress. We've all seen these patients. She takes an SSRI. By the way, she's 50 years old with a non-contributory medical history, and she has an otherwise age-appropriate dentition. Of relevance, the crown, or the onlay on number 30, the eMax onlay, was dislodged or became dislodged and re-cemented 4 weeks ago. Again, no issues prior to the dislodging of the crown. There was nothing, no trauma associated with this. The crown just fell off, and then it was re-cemented. Before we continue to talk about this, I want to advocate for everybody to have what we can call a standard diagnostic test for emergency appointments. As somebody who has spent a lot of time with young dental associates, as somebody who was once a young dentist, and somebody who has coached other dentists along the way, for some reason, when patients come in for limited exams, there doesn't seem to be a standard process that's employed much of the time. So I'm going to advocate right here that you create your own, we're going to present one, but create your own standard diagnostic process that you just get in the habit of using each and every time a patient comes in for an emergency exam related to an odontogenic problem. So patient comes in with pain. It is the standard of care. So it's important to note that this is the expectation of our state dental boards to, one, have a good standard testing process for diagnosis, but also documenting it well. So first and foremost, what is the evaluation of the radiographs? Simply having the radiographs is not necessarily where the end of the road is. It's what do we see on the radiograph and what do we think that information means that's important. Cold testing. This is one that seems to take a back seat much of the time when it should take the front seat. The point is, it's a good habit to always cold test a tooth unless there's a very obvious periapical abscess, but even under those circumstances, one could surmise that you should do it. What I'm advocating for here is have a standard process and make sure cold testing's in it, and just get in the habit of often always doing it. EPT testing is helpful if you have a negative cold test. Sometimes it's helpful to get further information about the pulp vitality through the use of EPT testing. Percussion, for whatever reason, this is the one that almost every dentist does, but we omit cold testing. Make sure percussion's in there, palpation, use the tooth sleuth some of the time. There's a lot of information that can come from this. It's not just for cracked teeth. It can be used for trigger points and a variety of other different reasons, but that should be part of your diagnostic process. And then there's a series of other things that sometimes you'll use. Transillumination, Carey's indicator dye, trigger point evaluations. These are topics for another day, but we're advocating for everybody to have their own process that they just get in the habit of always doing. In our office, we use a kit, so it doesn't always end up being used, but we have a kit that is intended to act as a standard process to make sure all T's are crossed and all I's are dotted and every stone is turned over. There are times when I'm surprised at the results I get from some of these testing that I probably thought initially I didn't need. What do we do with this information? We come up with a diagnosis. Recently, the American Academy of Endodontics came up with their revised diagnoses. As we all know, there's a pulpal and apical diagnosis. A normal pulp is a diagnosis in conjunction with an abnormal apical diagnosis. So when you have a clinical situation, you should have one of these and one of these. This information is readily available online. The American Academy of Endodontics has this. Please let me know if you need a copy. But it's really good to understand what these are. Again, they're different than they were 10 years ago, but the point is we need to have it. So coming back to the tooth in question, we went through our standard process. We did cold testing first. That was normal. Percussion was slightly painful. The tooth sleuth was normal. There were no probings greater than 3 millimeters. There was no mobility of the tooth. The occlusion was normal in MIP. And radiographically, there was a normal peri-apex. And number 29 was normal in all of these parameters also. So this is interesting. Patient's in a lot of pain. The pain is constant. It's not necessarily elicited by anything, although exacerbated by certain foods. Really, the only thing that we were able to induce was pain upon percussion. Well, that's not enough for a diagnosis. At least I'm not that good to then say exactly what's going on. So what we do need to do is come up with maybe a tentative diagnosis. And based on the landscape of diagnostic testing that we did here, we can say normal pulp with symptomatic apical periodontitis. That doesn't necessarily allow us to then go ahead and treat. You're not going to do a root canal based on that. But we do need a diagnosis, and there's our tentative diagnosis, unless we get additional information. And that's where we have to start putting our thinking cap on. Where do we go to get additional information to convert this tentative diagnosis to a definitive diagnosis? Well, this particular diagnosis, if you ever conclude that this is your diagnosis, we can sometimes say this is giving us a hint. And that hint might be that there is a acute occlusal microtrauma. That can come from a variety of different things. So if that's true, I almost always will then say, I'm going to take a closer look at the peri-apex. So if we take a closer look here, one might say maybe there's a little widening here. Now, when you have acute microtrauma, you're not going to see significant widening of the PDL because the body hasn't had enough time to resorb through the induced inflammation a widening of the PDL. You'll often see widening of the PDL with chronic microtrauma or occlusal trauma. But when it's acute, and here we're saying acute based on the patient's symptoms, we don't always see it. At least it's not super relevant. But you can see here that that's different than here. Okay, so why don't we continue to investigate the idea of supporting our diagnosis through microtrauma? We do have a CAT scan, so we're able to look at the transverse or axial image here. And there maybe appears to be some widening here. We're not going to go through the entire set of images. The purpose today is to articulate something else, but let's just say for the sake of argument that this is suspect, no different than the periapical PA image, two-dimensional image was. Suspect. And what I will say, when a tooth root lives close to the bone, whenever there's inflammation based on the fact that this bone is more dense, there's less room for the inflammation to go, the pain tends to be more profound. if our diagnosis is correct. So I just want to say that if you have a CAT scan and you see the root sitting close to, or the apex being close to that cortical bone, just keep in mind that sometimes that's enough to set this clinical situation apart from a situation where the apex is sitting in the cancellous bone, where the inflammation and the fluid associated with it is more able to be dispersed. That's not the emphasis of today's conversation, but just something I wanted to bring up. So here we have a patient who presents with a problem. We're trying to understand a little bit more about what's going on. I want to take a slight detour. This is what I would consider one of the most important, highly misunderstood aspects to what we do in clinical dentistry. And it comes to this guy here that we probably haven't seen since our dental boards, Poiseuille's envelope of motion. And although it's not the Poiseuille's envelope of motion that's important, it's a concept that lives within it that I think is extremely relevant for every restorative dentist, and every dentist for that matter, to have full understanding about. We all recall this diamond-looking diagram, or sawtooth, whatever was described, which is essentially the border movements of the mandible. So this is a zone where the mandible can go in three-dimensional space. It's drawn, this outer border is a drawing of a fictitious dot on the incisal edge of 24 or 25, and it's a jaw tracing as the mandible is moving in relation to the fixed maxilla, where it goes in three-dimensional space. We have our mandibular rest position, EMA position. That's essentially where the mandible goes during rest. That's the maximum intercuspal position, MIP. This is anterior guidance. That's the incisal edge. That's crossover, so on and so forth. Of this entire thing, the only time that's really important is when we're trying to measure for range of motion, when the patient has some sort of TMD issue. But when it comes to restorative dentistry, this is not very relevant. This teardrop zone here, which is also called the mandibular hinge movement, but I think it's more accurately termed the zone or the envelope of function. This zone here is really where our focus and attention is today. So again, the envelope of function, which we're going to call that from now on, sits within the envelope of motion. And this envelope of function is a zone that we find ourselves in during mastication, phonetics, and swallowing. When we are in that zone, we have to ask the question, are we free within that zone? So Dawson used to call it freedom of motion or harmony with anterior guidance. There's lots of ways of describing this. I would encourage everybody to understand this teardrop and apply it to your clinical practice. I bet each and every day you would find problems with patients because of an interference within that zone. And we're going to talk more about that here. So here's a very nice diagram. On the left here we have what we would consider a normal interincisal angle. In the world of orthodontics, they say something around 135 degrees is the proper orientation. As restorative dentists, we tend to think in the phraseology of overjet and overbite. But normal relationship, we'll call that a normal class 1 relationship. This particular example has a very nice wide envelope of function that lives within the envelope of motion, which is this dark blue zone here. The arrow is indicating that's where the mandible lives. As we can see, as the tooth becomes more upright and that interincisal angle becomes closer to 180 degrees, we can see that we're becoming rather restricted. So the mandible has less space for it to go. Now what's important to note is the muscles and the neurology that control this particular function, they don't necessarily know or care where the teeth are. They're not aware of that per se. So if the muscles and the neurology that control the muscles want this incisal edge to live in this zone here, we might have a problem. We would call this a restricted envelope of function. And restricted envelopes of function cause all kinds of problems. It's the reason we break teeth, it's the reason we break veneers, it's the reason patients have wear facets, it's the reason why there's fremitus and mobility, periodontal disease. The list goes on and on and on. And I'm just kind of amazed that dental schools don't spend an entire semester on this concept alone, because it's often the reason problems happen. If there's a biomechanical breakdown, more often than not, this is relevant in some form. Over here we have a severely, class 2, div 2 situation where there's a severely restricted envelope of function. Spear would call this a pathway wear patient, where the incisal edge would spend a lot of time wearing it down. Dawson called this particular situation the envelope of function, but he phrased it that it needs to be in harmony with anterior guidance. And what he's saying is, as the mandible slides down and forward, it should live just on top of or just outside of the envelope of function for there to be muscle harmony. If that, well, I think I've made the point. So very important. If you don't own this textbook, I highly advocate you do. If there's one textbook you're going to have in your career that you actually read front to back several times, it's this one. Dawson's information and theories and concepts could be argued are rather antiquated, some of them anyways. This is the best front to back read on introducing you to the concept so that you can develop your own religion of occlusion or religion of comprehensive dentistry. There are other camps out there, LVI, Coyce, Spear, Pankey, so on and so forth. They don't have a textbook to my knowledge. This is easily purchasable online. I would recommend everybody to get it, read a chapter a month, a chapter a quarter, and I promise you, you're just going to become a better dentist and have better and deeper understanding on how the patient presents to you with an isolated tooth problem that lives within a system. What I love about this book is it teaches you about the system, not just isolated tooth problems, which is what we learned in dental school. I talked about John Coyce earlier. This slide comes from his trainings. I would say this is probably the most updated description and definitely the best diagrams that talk about this particular envelope of function. In the middle here is the envelope of function with this really nice green zone. Dysfunctional and constricted, for the purposes of this argument, those are both abnormal envelopes of function. Just to put this in the summary, I'm trying to devise a phraseology that best articulates what this entire concept entails, and this is my current attempt at that. Two objects cannot occupy three-dimensional space at the same time, as the maxilla and its associated teeth are fixed. The three-dimensional intersection of the teeth is determined by the mandible, its muscles, and the concurrent neurology. It's this three-dimensional intersection that we're focusing on. Is it an intersection that is harmonious or an intersection that is chaotic? Furthermore, if the muscles and the neurology prefer, for whatever reason, whether it's airway-driven, centrally mediated, process-driven, whatever reason, there's lots of reasons why the muscles and neurology have preferences. If they prefer to have the mandible and its associated teeth in a three-dimensional position that is currently occupied by the maxillary teeth, here's the kicker, bad things can happen. This is the whole entire argument here, is that we have to understand that teeth can get in the way of each other when they're under function. So here's where we're going to take another detour back to our case vignette. This concept has been articulated rather clearly for anterior teeth, but not so much, at least to my knowledge, in the posterior. I want to introduce the concept, at least to my knowledge, this doesn't exist in a high degree of clarity, the concept of the posterior envelope of function and constricted posterior envelopes of function. So here we have a simple two-dimensional image of the first molars relating to each other. And we can think about that lower molar, which is attached to the mandible, which is the moving aspect of this relationship, as it having its own envelope of function. That's normal. That's this green triangle here. One could think, what's this line here represent? Well, that could be canine guidance. As the mandible goes to the side, this tooth is discluded from the upper tooth. We know back teeth don't like to touch during lateral motion, most of the time anyways. It's our immediate posterior disclusion which creates this line right here. we could talk a lot about this triangle. The point is that there's a normal zone, and we could think of this triangle as the normal zone. Well, if there's a normal zone, what about an abnormal zone? Well, if the mandible, again, driven by its neurology and the muscles, want that cusp tip to exist in three-dimensional space where the upper tooth is currently occupying that three-dimensional space, bad things can happen. In this particular case vignette, we're thinking that maybe there is an interference which is causing radiating, I won't say radiating, but causing a force or a microtrauma to the periapex of the tooth where we have very sensitive nerve endings. And those A delta fibers can be rather intolerant to inflammation. So in this particular scenario, we could come up with a diagnosis, which is microtrauma-induced symptomatic apical periodontitis with or without a normal pulp. In this particular case vignette, we have a normal pulp, so here's our diagnosis again. I added microtrauma-induced because I'm starting to get more sense that there might be an actual interference with the teeth. As we can see here, this is a two-dimensional image of the 3D CAT scan. It's one particular slice in three-dimensional space. But you can see here there's no interference here, but there's definitely an interference, or at least a very intimate relationship between these two inclines. We've all seen wear facets on lower molars that look like this, and when they happen over a short period of time, a long period of time, patients adapt to it fairly well. No different than water eroding a rock into a very smooth sphere over many, many years. This can be done and create a smooth surface that's well adapted by the patient. So presence of this alone is not necessarily something that's worthy or necessitating treatment. But in this particular case, we want to ask the question, is that relevant here? Let's take a look at another image. This is an axial slice, slightly more distal to this particular tooth. You can see a rather significant wear facet. Now, wear facets are not normal. We know teeth don't erupt into the mouth with flat surfaces like this. The only way flat surfaces can happen is if we have one of these interferences we were just talking about, quote unquote, a posterior constricted envelope of function. And you can see this very significant wear facet. So again, I want to reiterate that sometimes patients adapt to these particular situations, so when you see them in the absence of signs and symptoms, it's not necessarily a problem, but sometimes they are. And sometimes when you make changes to these particular teeth, it can really disrupt the overall system. So understanding how these systems work when you're doing single tooth dentistry is really the point here. Again, we have this red zone that lives above the blue line. If the mandible wants the cusp tip here to live in that zone, bad things can happen. But what caused this? So we talked a lot about general circumstances when we can have posterior constricted envelopes of function. But let's take a look back at the history to see if we can maybe gain a little bit more understanding on why this all of a sudden became a acute problem to a patient that has been having no issues for almost a decade. So here's the history of issues that we went over earlier. Well, we can notice here that the crown dislodged and was re-cemented 4 weeks ago, and that's when the symptoms happened. Well, can that be a clue to what may have gone on here? As we can see here, there's a cement gap. I can't say whether or not that's an overhang or normal or not normal, but it brings my attention to the cement gap, and I want to ask the question, what's different about adhesive cements? I would encourage everybody to pause this and just think for a second, because I think this is a rather important thing that we're about to uncover here. As we know, I put a couple diagrams for diagrammatic purposes, that the cement that lives between a crown and the prepared tooth come in a variety of different forms. We have resin-modified glass ionomers and resin cements, which would be the two major categories of cements that we have today. They're two different materials with two different indications, two different film thicknesses. There's a lot of different things that are associated with these two particular cements. But the one I want to highlight here is the fact that resin cements are more viscous. If you've ever used one, I think you know what I'm talking about, compared to RMGI cements and other cements that are out there. They're more viscous for a variety of different reasons, but what that leaves us is a rather thick zone right here. And if and when a crown comes off, I would say 99 times out of 100, that adhesive cement is going to be attached to the tooth and not the crown, because the bond to dentin is a lot stronger than the bond of adhesive cement to the lithium disilicate most of the time. Now, depending upon the skill of the technician, the condition of the tooth that's on the underside, that may or may not be relevant. The point is, you have to ask the question, is that adhesive cement still attached to the tooth after that crown comes off? Why is that important? Well, the cement gap for adhesive cements is rather thick. 50 to 200 microns might be a good estimation. This is not a fact, this is just my hunch. The point is that it's rather thick, which is why resin cements they perform better with milled restorations, which have larger gaps. But the point is that if that cement gap is still attached to the tooth, and then we go to re-cement the crown and we add another layer of adhesive cement, what's happening to that crown? Well, we can imagine here that there's not a whole lot of space here, and you saw in one of the axial slices that there was zero space right here. Well, if there's zero space there, and we re-cement a crown that already has, let's just say, a 100 micron cement layer that's attached to the tooth, and then we add another 100 micron layer to it, are we then putting that tooth in hyperocclusion? And I think the answer was yes. I think that's what happened here. I'm not going to get into should the resin cement be removed, and if it's removed, how do you know you removed it all? That's a topic for another day, but the point here is that when we re-cement adhesive restorations, cements that were placed on that we can't see and readily pick off like we can with some of the more luting-based cements, I think we have to be a lot more cognizant in the resulting occlusion that happens as a result of re-cementing that crown back on. So what do we do? Well, the answer is we need to remove the functional interference. That functional interference did not exist when the eMax was originally placed. Well, maybe it did, and that's why we see that flat surface, but it was done at a time that it didn't cause pain to the patient. She adapted to it over time, but now we have an immediate functional interference combined with a patient who spends a lot of time in that type A personality, which translates to, let's just say, more muscle activity of the jaws, and as a result, you're likely to see problems arise. And the straw or the weakest point in the system, I think in this particular case, was the periapex, and that's why the inflammation happened and why we had our tentative diagnosis. So when this was cemented back on, the provider did what we're all taught, which is tap, tap, tap with any color paper, just to confirm in MIP, is it okay? But we know MIP is not the only occlusal scheme that we need to account for when we do restorative dentistry. We only live in MIP when dentists say tap, 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 and when we swallow. So the only time our teeth come together is when we're actually in the swallowing pattern, which is, a fraction of the day. It's really the functional motion that we want to gain more understanding on, and that's why I brought that concept up here. How can we gain more understanding in where that functional envelope of function exists? Well, the first thing we can do is start with a different color paper than the one that we had tap, tap, tap with. Here we're going to use red. So here we have the patient tap and then grind left, right, and forward. You have to watch patients do this. It's hard for them to do it, so you really want to get a sense, are they doing it? What we're trying to find are potential lateral interferences. And then we want to remove all the red that's not superimposed on the blue. So this is the cooking instructions on how to determine envelopes of function in the posterior. Let's take a look at a diagram here. So this particular diagram I got online was a very, very clear representation of what we're trying to talk about here. As Dawson said, dots in the back, lines in the front. Well, one could say that this red dot is the creation of a line. Why is that there? Let's have a separate conversation on how to discern and read occlusal markings. But I can tell you that this lone standing red dot is a potential interference. And more often than not, when you see these, you see abfractions, because the lateral displacement of the mandible is stressing this tooth in and of itself during that motion. That's an interference in the envelope of function. Tap, tap, tap with one color, tap and grind with the other, remove whatever is not superimposed. And you can see here there's a little red here. You have to learn how to read occlusal markings, and there's several good videos online on this. The point is that wherever the red is not superimposing on black, you would then adjust that. What you're doing is you're removing a potential interference in the envelope of function in the posterior. Keep in mind that a line on the canine is expected, and that's canine guidance. In the anterior, same thing with protrusive guidance. But here, we're just talking about these balancing interferences or working side interferences, and they can exist in other dimensions also. But we want to understand what these are, how to find them, and then adjust them. So this is the zone that we're talking about right here. I chose the best shape that I could. Just keep in mind that sometimes there's an interference between upper and lower teeth, not in MIP, but during dynamic or functional movements. But what if the patient does not have canine guidance? In other words, these teeth are going through touch simply based on the fact that there is no canine guidance, and that can happen. So here we need a different tool. And that tool is starting to find its way into, Coyce is starting to talk about this. I don't know if it necessarily has a name, but we can call it the masticatory test. And again, the answer is here to remove the functional interference. But when we talk about this masticatory test, what we're going to use is chewing gum or soft rope wax on the contralateral side. You can do this in the anterior also. So you're going to have the patient chew out back. What that's going to do, it's going to bring in neurology, muscle movements, breathing, in other words, function, into our occlusal analysis so that we can answer the question, is there an interference or not? 200 micron paper, articulating paper, seems to be the recommended thickness, which is very thick. If you use denture articulating paper, somewhere between 70 and 80 microns, if you double or triple that up, you're in the ballpark of getting some understanding on how to ensure that there's not an interference during these dynamic or functional movements. So you have the patient chew on one side, and then you insert the articulating paper on the object tooth that you're trying to get understanding about. In this particular situation, it's this tooth right here. And then you remove any markings on that tooth. So you have, if you do tap, 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 tap and grind, you have to polish off all of those markings to do this. And we'll often do both of these. Sometimes the information is the same. Sometimes the information is different. But I like having both of these tools in the toolbox. When you switch from one to the other, just make sure to remove the occlusal dots because the information on the teeth is different. You can polish those off rather easily. So what was done for this patient? Well, the doctor then removed the functional interference. So there was a doctor that cemented this crown. The patient then came in a couple times, saw some different providers, and it was this final doctor that brought the case to me, and we kind of worked this out together. And what she had done is she did the first test, the tap, 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 tap and grind, and then removed the interferences. Patient noticed an immediate improvement. And then she did the masticatory test. Again, there's probably a more updated name at some point that'll arise within the profession on this particular functional occlusal analysis. And the patient felt better even further. So one could surmise that our diagnosis was correct. Again, she used the 2 previously described methods, and then the patient reported feeling better immediately. We did a 2-week follow-up to confirm treatment success. The patient said she felt better each and every day. It was still sore. Again, this is kind of like a bruise when you have occlusal microtrauma in an acute sense. The patient can still have pain when they're chewing, but the impetus of the discomfort is gone. So the body will heal and adapt as time goes on. So that's the end of the case vignette. And really what I wanted to do here was show that sometimes the answer is slightly less obvious than what we might think. This would be a typical scenario where a general dentist will send this to the endodontist, and this is not a slander to the endodontist. I know many endodontists that would be able to come up with this particular scenario, but I've worked with endodontists who are very good at treating, but diagnosing, especially with occlusal interferences, may be slightly weak. Again, it's not a slander to endodontists. This is an advocacy for us as restorative dentists to be able to diagnose these situations when it's a functional and restorative-based problem. Work closely with your endodontic colleagues and work with those that understand this stuff. You'll find that your patients are going to be treated better as a result. So here we have several different aspects that we covered today. The high point is when a patient presents with non-obvious symptomology, think a little bit deeper and see if you can unravel it through analysis of the occlusion, trigger point evaluation, so on and so forth. So we're going to end with that. Please leave a comment. Let me know if this was helpful. I hope to do one of these a week, which are very clinically relevant to our everyday providers. As general dentists, we have lots of challenges, and our goal here is to help clinicians become better through seeing cases just like this through something as simple as a YouTube video. So I hope everybody has a good day, and we will talk to you soon. Take care.